when members call 1-800 Medicare and says my health plan isn't giving me the items or services that that are needed. Those are things that get escalated to my level. Congressional inquiries. A lot of the times members will reach out and call their congressional offices as well and say, hey, I'm not getting A or B service from my health plan. Can you investigate it? So anytime those congressional items come in, they always go to the compliance officer for review and potential intervention.
If you think regulatory pressure is about compliance checklists, then you're missing the real story. It's operational architecture. I went to my regional HCCA conference not to talk about audits, but to understand where enforcement pressure is exposing weak decision infrastructure inside of health plans. These are different leaders, different states, different organizations, and they all describe the same structural vulnerability. Monitoring does not fix what contracting already created. So this isn't a compliance episode, but I do want to make a point about durability right now. My lens isn't regulatory, it's strategic. I listen for where enforcement pressure reveals margin fragility, where documentation economics break, and where delegation multiplies risk, and where governance lags behind innovation, because that's where enterprise exposure lives. The first signal was about delegation. Plans are delegating more authority, behavioral health, dental, transportation, vision, but many are not upgrading governance infrastructure to match it.
First, I'm Charles Baker. I'm Senior Managing Director with Incremental Consulting Group.
What's the most common oversight issue that traces directly back to how a decision was approved?
The most common is the appropriate application of internal medical criteria. So when you're thinking about your internal medical criteria, making sure that your medical directors part of that, as well as like your utilization management committee, all organizations from a managed care perspective should have a utilization management committee that is reviewing both your internal policies and procedures around coverage and determinations, as well as those of your vendors. So if you are delegating decision-making authority to delegated providers, it's very important that you are reviewing those internal policy criteria as well.
Delegation does not reduce liability, it expands surface area. If your medical directors and committee are not actively reviewing vendor criteria, then you haven't outsourced risk, you've distributed it.
I'm Mary Alice Jameson, and I am from Presbyterian Health Plan. I'm the Director of Program Integrity, which oversees the Special Investigative Unit and the Accurate Provider Payment Unit. We actually audit our vendors on a routine basis to make certain that they're doing case investigations and to also make certain that they're doing those investigations timely. We also review their documents that are related to program integrity, and we audit those as well to make certain that they're in alignment with our contract. So when we were getting ready for the UPIC audit, we actually had our vendors involved because part of the universe information that was pulled involved those vendors. So we would meet with them on practically a weekly basis and make certain that they understood their cases in case they were pulled. And so we are very active with oversight with our vendor community.
Many organizations that hold up under pressure rehearse. They assume vendors are part of their audit universe. They don't wait for enforcement to expose gaps, and they engineer defensibility upstream. Monitoring is not a cleanup function. If you're leading operations, delegated oversight, or enterprise risk inside of a health plan, that is what I track at Pull. This is an audit theater. This is where structure pressure points are before they become headlines. Please subscribe so that we can ensure that nobody gets left behind. Now we're back with another pattern. Appeal, grievances, and CTMs are stress signals. What usually forces escalation to your level?
So in terms of CMS, when we're getting CTM, so complaint tracking module assertions, which is when members call 1-800 Medicare and says my health plan isn't giving me the items or services that are needed. Those are things that get escalated to my level. Congressional inquiries. A lot of the times members will reach out and call their congressional offices as well and say, hey, I'm not getting A or B service from my health plan. Can you investigate it? So anytime those congressional items come in, they always go to the compliance officer for review.
When members escalate, when congressional offices intervene. Those aren't customer service friction points, they're a breakdown in defensibility.
If you see a number of appeals from a member, for example, that are based on a specific item or a service, then you may want to look at your internal coverage policy for that item or service.
If you see a concentration around one service category, you don't have a denial problem, you have a criteria alignment problem, and that misalignment compounds over time. Documentation surfaced in nearly every conversation. Lack of specificity, incomplete records, misaligned diagnosis coding.
A lot of the times when providers are requesting items or services to managed care organizations, they're filling out the plan's prior authorization form, right? They're attaching medical records, but there is a lack of specificity around those requests, right? So if they're requesting an MRI, for example, then the discrete reason for the need for that MRI can sometimes be lacking within the medical record that the organization or the provider is providing, or they don't attach the medical records at all and they just do the prior authorization form. And sometimes that's not enough for the organization to be able to make that determination.
My name is Ray Evans. I'm the Vice President of Sales for the Healthcare Division of Covent Bridge. Does the documentation substantiate the diagnosis code? What is their services rendered? Did the member actually go see the provider? You could have potentially 3 codes for a similar condition. So which one is accurate?
Most exposure is incremental. A slightly thin medical necessity rationale, a slightly misaligned code, a slightly incomplete attachment, but enforcement doesn't grade intent. It evaluates control architecture. Documentation gaps become approval gaps become reversal rates, and those reversal rates become findings. So more than just auto survival, this is documentation economics.
I am Jala Atia. I am the president and founder of Integrity Advantage. And what issues usually aren't fraud, but still fail assessment? Yeah, so some issues that aren't fraud. And the thing about fraud is we don't determine fraud, right? The fraud is determined by a court of law. So we don't like using the F word. But a lot of things could be more waste and abuse, things that are outside the standards of care, but not necessarily harmful to patients, things that aren't illegal, that aren't like intentionally done, a lot of errors.
Most findings are process fragility under stress.
Good train. So if we get leads, we don't think there's intent or it's egregious, we'll train them and then we'll monitor them over a period of time to make sure they're walking the straight line.
Strong programs don't just detect, they tighten, educate, recalibrate. And this is the difference between waste and fraud that often comes down to governance speed.
I'm Wendy Edwards. I work at Blue Peak Advisors. I'm area vice president.
What's the most common reason why people don't pass audits?
From a perspective of a health plan, the reason that they don't pass audits is typically because of lack of internal processes. There's protocol that they can follow, but they really don't have the processes in place to ensure that they can give the right information. It's not that they're not doing what's required. It's that they can't document it because they can't follow their internal processes.
So when you say internal processes, is there like 3 core steps to that?
I mean, I think they would need to have, their what's required, right? Understand what's required, have that documented, and then who's doing it, right? And then at what intervals they're going to follow. So they have clear protocol, what's happening, who's doing it, and how it's being followed up on. And then
what are the most common blind spots for people?
So I think a blind spot could be that you don't have systems that can talk to each other. So it's the lack of the technology and the systems. And then you have turnover in organizations. So I think those are 2 big things that happen where you have turnover and people leave. And because it's not well documented, right? The new person comes along and then there ends up being a gap.
Plans are often doing the work, but they cannot consistently prove it. Systems don't talk. Documentation isn't standardized, or maybe turnover erodes institutional memory. But under pressure, that fragmentation shows.
My name is Regan Pennypacker. I currently work at Audit Consulting. Compliance is an art form, not a science. right? When there's a lot of ambiguity or when something comes up that's really brand new, something that hasn't been tried before, a lot of times we don't have, regulatory guidance that's around it, or even sub-regulatory guidance, no memos, no thoughts, no FAQs. And so should that stop your progress? It really depends on your risk appetite. Sometimes you just have to take that innovative step and get creative. And then sometimes you're educating the regulator to say, this is how it works. These are the results that we've gotten. And this is how we got there by being creative. So you can have that good, confident conversation if you innovate in the right way.
Innovation is not the risk. Weak documentation around innovation is. The organizations shaping guidance tomorrow are the ones building receipts today. The most striking thing about these interviews isn't the advice, but the pattern consistency. Different organizations with the same stress fractures. Delegation without governance, documentation without clarity, monitoring without architectural alignment, and data without interpretive control. Enforcement doesn't create fragility, but it reveals it. Healthcare is struggling with structural precision. Plans that navigate the next cycle successfully won't be the loudest, they'll be the ones who rebuilt decision infrastructure before anyone forced them to. Pull exists to surface those structural signals early. If you're responsible for enterprise durability, not optics, subscribe. We track where governance pressure meets operational economics.